Well, welcome everyone. It's the top of the hour, so we will get started. I'm Dia Waguespack in Houston and like to welcome you to today's GlomCon seminar. Today, the title of our talk is Protective Effect of Variant p.N264K in the APOL1 gene against APOL1 mediated kidney disease. And we are excited to welcome our speaker, Dr. Adriana Hung.
Well, thank you so much, Dia, for that introduction, and thank you for the opportunity of sharing about this very exciting talk here today. I'm going to try to see for a moment. Let me see if I can I share my screen? I guess, yes. Perfect.
Yes, it looks perfect.
Okay, wonderful. Yeah, and so what I really wanted to talk today about is recent work that has been done in genetic modifiers of the risk of AMKD through high-risk APOL1 genotypes like G1 and G2. And so that particularly is this new recognized variant, N264K, which is really important because it provides an opportunity for classification of the risk of APOL1, G1, and G2, and for clinical management in new therapeutics. Yeah, so what I'm going to cover first, just a very brief overview of the epidemiology of CKD, with focus on inequalities in CKD and in SKD and APOL1. Then I'll talk and cover the studies that prompted the study of these very particular variant in human populations. I'll cover the two studies that there are, but they're very strong and provide the human genetic proof of the protective effect of these modification by APOL1 into 6-4K. That will be one by my group and one by the group of Colombia. The paper is by Gupta, by really Simon Sanekirky. And then I'll talk about the contribution of common variants into the risk of AMKD through polygenic risk scores and other circumstances. And I will even talk about APOL1 mediated kidney disease in patients with diabetes, which does happen, and the implications for their. So we're all very familiar with the fact that, at least in the US, individuals of African ancestry have an excess risk of ESRD. And so their lifetime risk of ESRD is about 8% compared to 3.5% in individuals of European ancestry. And this particular slide is a slide from the USRDS, in the United States Renal Data System. And in part, for many years, that excess risk has been explained partially by the presence of the APOL1 high-risk genotypes. And I'm sure that we all are very familiar with this work by Barza et al. That was published in 2013 in the New England Journal of Medicine. And that was done in two cohorts, the Creek and the African American study of kidney disease cohort. I really like to highlight the work done on the chronic renal insufficiency cohort because they kept in the comparison the European ancestry. And so if we compare a high-risk genotype patient or population against individuals of European ancestry in the risk of reaching a renal composite of 50% decline in kidney function of ESRD, they will have a threefold increase in the risk of reaching the renal composite. But what I really want to highlight is that if you compare the low risk against the European ancestry individuals, or white in this case here, there's still a significant excess risk of reaching the kidney end. And I'm highlighting that part because we are doing a significant amount of work in trying to understand that excess risk, which I may not cover today, but I can tell you a little bit that some of the important things include G6PD, is sickle cell trait and sickle cell disease.